Good evening and welcome to session 2 of our virtual patient education series, 2020 New and Emerging Treatments for Blood Cancers. My name is Carrie Callis. I'm the Director of Programs at the Leukemia Research Foundation. We are pleased to present this event in partnership with the Cardinal Bernardine Cancer Center at Loyola. We're grateful to have our presenters this evening, Dr. Sonali Smith and Dr. Nasheed Hossain. We would also like to thank our supporters of this program, AbbVie, Jazz Pharmaceuticals, Karyopharm Therapeutics, and Novartis Oncology. As a brief background about the Leukemia Research Foundation, the Foundation's mission is to conquer all blood cancers by funding research into their causes and cures and enriching the quality of life of those touched by these diseases. Since its inception in 1946, the Foundation has funded over $80 million of research grants to over 500 new investigators on 5 continents and supports patients and families living with a blood cancer diagnosis through educational and support programs. I encourage you to visit allbloodcancers.org to learn more about our patient support programs, including our online support community and our comprehensive listing of resources. So at this time, I would like to introduce our moderator of tonight's program, Dr. Patrick Stiff, who is the director at the Cardinal Bernardine Cancer Center at Loyola University. He's the chair of the Foundation's Medical Advisory Board, and we thank him for all he does to advise and support our work at the Foundation. Our next presenter, we have Dr. Nasheed Hossain from the Cardinal Bernardine Cancer Center at Loyola. So Dr. Hossain, if you would like to get started and introduce yourself, that would be great.
Okay, so my job today is to tell everybody a little bit more about chimeric therapy and how this kind of falls into the treatment paradigms for aggressive lymphomas and leukemias. I have no actual potential conflicts of interest in relation to this presentation. However, I may be discussing some non-FDA approved techniques, including new models of CAR therapy for a variety of indications. So a little bit of learning objectives, a little bit of a to go over during this evening's talk. A quick review of chimeric antigen receptor CAR basics. Looking at our experiences with CARs in large cell lymphoma as well as acute lymphoblastic leukemia. I talked a little bit about some of the toxicities related to CAR T therapy. Then a quick thing about what our experience has been at Loyola thus far with the CAR T cells, including our own in-house CAR T trial. And of course, after that will be questions from the audience. So why don't we get started? So, what exactly is this CAR T cell therapy? What does this mean exactly? It utilizes a gene transfer technique or techniques to reprogram a patient's own T cells. The target is defined by a customized T cell receptor, a construct that's known as the chimeric antigen receptor itself. There are a variety of ways to actually introduce this construct or this piece of code into a T cell, including using other viruses such as lentiviruses, retroviruses, also using transposons, which are those small pieces of DNA. To date, there have been many different constructs that have been developed and tested both in the lab and in clinical trials, and a variety of antigens have been targeted in a variety of diseases, including lymphoma, leukemia, and now in a growing number of solid cancers. Now, this is a very nice way to illustrate what exactly is a CAR T cell. What is a CAR construct? On the left, you have what nature has given us, our T cell receptor, which is a very intricate grouping of a variety of different molecules that act together to tell our own T cells in our body to recognize and attack foreign viruses, bacteria, etc. When certain signals are being presented to them by other cells within the body. With CAR T cells, we've taken what nature has designed and tried to simplify it down to what we think are the essential elements. including what we call a ligand binding domain, which helps the CAR T cell recognize its target of interest, and a variety of signal domains on the inner side of the cell itself that helps to tell the cell to turn on and start attacking both the tumor, but also to help to kind of turn on the rest of the immune system as well. The most common, signaling domains that we use include CD3, and there are other variety of ones that are listed right here, including CD28, CD27, ICOS41BB, and OX40. So what are the exact steps that are involved in making a CAR T cell? It's a multi-step process, first starting out with a procedure called leukapheresis, where we actually take a patient's T cells and collect them from their blood using a leukapheresis machine, and then take them to the lab, where they are then treated with the vector of interest, the virus or the transposon that allows us to get that CAR construct into the patient's own T cells. This is followed by letting those T cells grow in culture, letting them expand, and then quite a lot of quality checks to kind of make sure that we know exactly what is going on. One is to make sure that there's no sign of increasing virus activity, that the virus isn't spreading or dividing on its own. To make sure that the T cells are growing well and look happy and seem to be behaving well. Also to make sure that they're actually expressing the CAR construct that we want them to be expressing before this goes into the patient. And as well at the same time, even though this is in a closed system, we also do a lot of checks to make sure there's no sign of any kind of contamination, bacterial, viral, or otherwise. Before these, T cells are then harvested, so to speak, and packaged into a infusion product that is then given to the patient, either as a fresh product or something that has been frozen and then infused, thawed and then infused to the patient, either in the clinic or in the hospital. In general, when you look at the different commercially approved products as well as the different clinical trials, the average turnaround time from the time that the T cells are collected from a patient to the time that they're infused into the patient can be anywhere from 12 to 45 days, with a variety of checks and balances in place based on being able to get enough T cells originally, and then also being able to produce enough CAR T cells that meet both the quality metrics that are in place by the FDA and different organizations to be allowed for infusion, as well as making sure that we have the dose that is intended for any specific indication. Now, what has the experience been so far with CARs in both large cell lymphoma and ALL? The current clinic experience really has centered on a couple of different trials I'm going to be going over, including the ZUMA-1 trial in non-Hodgkin's lymphoma, or large cell lymphoma, the JULIET trial, which is a different CAR looking at non-Hodgkin's lymphoma, and then the TRANSCEND trial, which is another kind of a take on CAR therapy in non-Hodgkin's lymphoma. And then kind of in combination, the ELIANA and ZUMA-3 trials, which look at both pediatric and young adult adolescent ALL, as well as the ZUMA-3 trial, which look at adult ALL. So first going to ZUMA-1. So who were the patients? The median age patients in this trial was 58, but approximately 27 or 25, a quarter of the patients were at grade age 65 or greater. There's a slight preponderance towards male patients, and 57 patients had a good performance test, what we call our ECOG performance centers of 1 or greater. 83% of patients had stage 3 or 4 disease, and the IPI is a scoring system where the higher the score, the more aggressive the disease. About 44% of patients had a pretty, high risk IPI score, and about 70% of patients had at least received 3 or more prior lines of therapy. In addition, when you look, the number of patients who are refractory, not responding to the most recent last line of therapy they received, was about 74%. And about 65% of patients had a progression of disease or had completely actually advanced through their last line of therapy. And about 23% of patients had already undergone an autologous stem cell transplant and had either relapse of disease or progression of disease following the transplant. As far as how well it worked clinically, the overall response rate for patients treated on the ZUMA-1 trial, about the approximately 108 patients, was 83%. 58% of patients had a complete remission or no sign of disease at the time of initial disease assessment, and 25% of patients had a partial response, or at least a 50% or greater reduction in their tumor burden. What we have seen is that the responses in the patients who are maintaining an overall ongoing response is approximately 39%, 37% of CR patients, and 2% of the PR patients, or partial response patients. In general, when you look at the entire group, the overall duration of response is 11.1 months, with the caveat being that the median duration for patients who had a complete remission has not been reached, and the median overall survival is 25.8 months. Now, when we look at safety, the overall grades of the toxicities that we worry about in CAR T-cell therapy include cytokine release syndrome, which is like having the worst flu you can imagine, where the immune system is in full gear and like releasing a lot of cytokines, really causing everything to be really flared up, and neurotoxicity, which can range anywhere from having problems sleeping, feeling anxious, to as serious as having seizures or swelling of the brain. And in the ZUMA trial, 92% of patients had some degree of this cytokine release syndrome. Now, grade 3 or greater cytokine release syndrome is really a cytokine release syndrome that is so significant that one has to be in a intensive care unit for closer monitoring, blood pressure support, and potentially even being on the ventilator. And in this trial, 11% of patients fit into that category, had that serious a degree of cytokine release syndrome that they developed. The time to onset from the time that they received their CAR T-cell infusion was approximately 2 days, with a range anywhere from 1 to 12 days. And it took approximately 8 days for the cytokine release syndrome to fully resolve. In contrast, for neurotoxicity, approximately 2/3 of patients, or 67% of patients, had some degree of neurotoxicity, and about a third, or 32%, had grade 3 or greater neurotoxicity. Usually the time to onset for this neurotoxicity was approximately 5 days, with a range anywhere from 1 to 17 days, and the time to resolution from the time of onset was approximately 2.5 weeks, or 17 days. To date, there have been 4 deaths that have been attributed to adverse events from the CAR T-cell itself. One was a patient who died of a cardiac arrest, one who had a kind of a very severe inflammatory response called HLH, one patient who had a pulmonary embolism, and one patient who had an intracranial hemorrhage. Of these 4 deaths, 2 was thought to be related to the CAR T-cell therapy itself. Now, the things to remember is, when you look at different papers or things of that sort, there are different criteria that are used for grading, and this was utilized using the LEAD criteria, which is becoming some derivative of which is becoming more of a more commonly utilized right now. And the CTCA is one of the guidelines we have from the FDA for grading these neurotoxicities as well. So now let's change gears to a slightly different CAR T-cell therapy. This is from the JULIET trial. Now, this was a trial CAR T-cell that, in contrast to the ZUMA 1 trial, used a slightly different design of CAR T-cell. Similar to ZUMA 1, which I failed to mention earlier, my apologies, this also targeted the CD19 molecule that is found on B-cell lymphomas, but had a slight alteration in the signaling domain on the inner part of the CAR T-cell itself. Now, what were the characteristics of the patients who were treated? Approximately 111 patients were enrolled on the trial. The median age for the patients was 56 years of age, and once again, about 23% of patients were age 65 or greater, and approximately 45% of patients had an ECOG performance status of 1. When you look at the different stages of disease that were enrolled on the trial, a majority of patients had stage 3 or 4 disease, approximately 76%. They also reported how many patients had involvement of the lymphoma in their bone marrow, which is approximately 7%. And a majority of these patients were diffuse large B-cell lymphoma, though a small component had large cell lymphoma that had arisen from a previous follicular indolent lymphoma. About 27% of these patients had a double or triple hit rearrangement or a double or triple hit lymphoma. 57% were of the germinal center B cell type, and 41% were of the non-germinal center type. And a majority of patients had anywhere from 2 to 3 lines of previous therapy, making up about 75% of the entire cohort. About 45% of patients had a relapse following their last therapy. About 55% had refractory disease. And about 49% had a previous stem cell, like an autologous stem cell transplant. We do note that this study did exclude patients who had primary mediastinal B-cell lymphoma, which is a slightly different variant of type of large B-cell lymphoma. Also excluded anybody who had had an allogeneic stem cell transplant or any patient that had active evidence of lymphoma affecting the brain or the fluid around the brain. So how well did it work clinically? The reported overall response rate for this trial was 52%, with 40% of patients having a complete remission and 12% of patients having a partial remission. At the last time of reporting, the median duration of response had not yet been reached, but the estimated progression-free survival at 12 months was 83% for those patients with a complete remission or a partial remission at 3 months following the CAR T-cell infusion. And the median overall survival has been reported at 12 months. Now, how safe was this CAR T-cell? Now, once again, we look at cytokine release syndrome and looking at the neurotoxicity rates for this CAR T-cell. 64% of patients had cytokine release syndrome. 24% of patients had grade 3 or greater cytokine release syndrome. For this CAR T-cell, the initial onset of cytokine release syndrome was approximately 3 days after the CAR T infusion, and it took approximately a week for the CRS or cytokine release syndrome to resolve. With regards to neurotoxicity, 23% of patients had some degree of neurotoxicity, and about 13% of patients had grade 3 or worse neurotoxicity. The onset of neurotoxicity was approximately 6 days, with a range of 101 to 17 days, and resolution once again was about 14 days. It took about 2 weeks for it to fully resolve. When we look at certain deaths that were reported in the trial, 3 patients died within 30 days of getting their CAR T-cell infusion, all of whom had passed away due to lymphoma progression. The investigators for this trial reported that no deaths related to the CAR therapy itself, and then to note the CRS cytokine release syndrome was graded according to a slightly different scale called the University of Pennsylvania scale. Now, let's look at a third model of CAR T cells that have been utilized in large cell lymphoma. This is the TRANSCEND trial. Difference from this is this had a slightly different constitution of CAR T cells that were being infused. And when you look at the characteristics of the patients that were enrolled, the median age was 63, with 42% of patients who were age 65 and older, and 10% who are age 75 and older. 51% of patients had large cell lymphoma, and approximately 22% of patients had lymphoma that evolved from a follicular lymphoma. About 3% of patients did have what we call secondary CNS lymphoma, or lymphoma that had initially started out in other parts of the body and had gone to the brain or the fluid around the brain. The ECOG performance status was was 0 to 1, about 99% greater in patients. 38% of patients was thought to have high burden of disease at the time of enrollment. And a quarter of patients had 4 greater lines of therapy prior to the CAR T cells. And a third of patients had previously undergone a autologous stem cell transplant, and 3% of patients had actually undergone a previous allogeneic transplant. 2/3 of the patients were thought to have chemo-refractory disease, and 44% of patients had never achieved a CR with their prior therapy, and approximately 60% of patients received some kind of bridging therapy, meaning they received some kind of therapy in between the time that their T cells were collected and the CAR T cells were infused to them. Of note, 89% of patients had what the investigators characterized as high-risk features, which they postulated would portend to shorter overall survival. This included high-grade / double-hit, triple-hit lymphoma, having an ECOG performance status of 2, having primary refractory disease, being refractory to second-line or later therapy, not having a prior autologous stem cell transplant, or never having been able to successfully achieve a complete remission with prior lines of therapy. So, what was the response in the clinical efficacy with this CAR? The overall response rate was 73%, with a complete remission rate of 53%, and a partial response rate of 19.5%. At 6 months, 60.4% responses were ongoing, and at 12 months, 54.7% responses were ongoing. The median overall survival was 21.1 months, and the median progression-free survival was 6.8 months. So how safe was this CAR? 42% of patients had some degree of cytokine release syndrome, with only 2% of patients having grade 3 or greater cytokine release syndrome. The median time to onset of release is approximately 5 days, and the time to resolution is also approximately 5 days. With regards to neurotoxicity, approximately 30% of patients had some degree of neurotoxicity following the CAR T infusion. Approximately 10% had grade 3 or greater or worse CAR T cell neurotoxicity, and the time to 9 days, and the time to resolution is approximately 11 days. They also reported how many patients had to go to the actual ICU, and about 7% of patients had to go to the intensive care unit, 4% of patients secondary to cytokine release or neurotoxicity, and 3% of patients for other reasons. They also showed some of the support utilized for patients. For patients who had cytokine release and neurotoxicity, a majority of patients received cytokine-directed therapy as well as steroids to help calm down their cytokine release or their neurotoxicity. And then for patients who had only neurotoxicity, a majority received steroids, and some received steroids plus a cytokine-directed therapy. And they also noted that the cytokine release and neurotoxicity were reversible for a majority of patients. One patient had an unresolved neurotoxicity, which was a grade 1 tremor at the time that the investigators made this report, and 8 patients had ongoing cytokine release or neurotoxicity at time of death from other complications. Now, a little bit more about some of the safety that this trial had mentioned is a third type of side effect that we may often see with CAR T cell therapy, which is low blood counts or cytopenias. The investigators for this trial noted that 37% of patients had grade 3 or worse cytopenias. About 12% of patients had grade 3 or worse serious infections ranging from bacterial to fungal or viral. One a worse lysis and had low immunoglobulin levels following their globulin levels for T infusion or hypogammaglobulinemia. Now, let's switch gears to talk about how well CAR T cells have worked in patients who have acute lymphoblastic leukemia, both in the pediatric slash young adult side as well as in adult ALL. First, the ELIANA trial. This was the trial looking at a CD19 T cell therapy in patients, pediatric or young adult patients with ALL. They had approximately 79 patients. The median age was 11 years of age. Most 57% of patients were male. 61% of patients had had a prior stem cell transplant, and approximately the median approximate number of therapies prior to CAR T cells was 3, with a range from anywhere from 1 to 8. 8% of patients had primary refractory disease, and 92% of patients had chemo-refractory or relapsed disease. They also looked at the amount of leukemia cells found in the bone marrow, and the median amount of leukemia cells in the bone marrow at the time of CAR T infusion was 74%. And then a number of patients actually had CNS involvement with their leukemia at the time of their CAR T infusion. With regards to clinical efficacy, the overall response rate for this CAR was 82%, with a complete remission rate of 62%. 66% of patients with a CR remission were in remission at 18 months beyond the CAR T infusion, and the overall survival rate was 70% at 18 months post CAR T infusion. Also of note, of the 15 of the 16 patients who did relapse had CD19 negative disease at the time of their relapse. How safe was this CAR? When we look at the experience with this trial, 77% of patients had some degree of cytokine release syndrome. 48% of these patients had grade 3 or worse cytokine release syndrome. The time to onset of cytokine release was approximately 3 days, and the time to resolution was approximately 8 days. In contrast, neurotoxicity was experienced by 40% of patients who were treated, and grade 3 or worse neurotoxicity occurred in 13% of patients. They did not report the time to onset for this neurotoxicity, but did note that the neurotoxicity usually lasted for approximately 2.5 weeks. Now, let's shift gears to what is the experience with the adults and CAR T cell therapy. Now, the ZUMA-3 trial looked at CD19-directed CAR T cells in adult ALL using a slightly different CAR than what was previously presented for the trial with the pediatric patients. They've, to date, based on their current enrollment, their overall response rate had been reported at 70%, with a CR rate of 68% and a partial response rate of 2%, with a median duration of response of 12.9 months. Safety-wise, the investigators have reported that grade 3 or worse cytokine release syndrome was experienced by 29% of patients. They did not give us very much details as far as time to onset or the median time that this CRS remained present. And with regards to neurotoxicity, 38% of patients had grade 3 or worse neurotoxicity following the CAR T cell therapy. And they've also reported 2 deaths to date on this trial, one due to a cerebral infarction and one due to multi-organ failure. Now, after having gone over these large multi-center trials, let's talk about what we have been doing here at Loyola with our cell therapy program. Working with Dr. Stiff and Dr. Nishimura, we have developed in-house have developed a CAR T cell that targets CD19, which is one of the most common antigens we see on these B cell lymphomas and leukemias. but it has a tag that uses a human CD34 surface marker. This is unique in that it gives us the ability to both purify our infusion product, but also track the CAR T cells without engaging the CAR from patients' blood samples following CAR infusion. This CAR currently being tested in a phase 1 dose escalation trial, where our main aims right now are to determine how safe this CAR T cell is and to determine what is the maximum safe dose. Also kind of giving us an idea to see how well and how successfully we can produce this CAR T cell for a variety of patients, and getting some preliminary data as to how well it works in the clinic. This is a quick diagram of the dose escalation that we're using, where it's 3 dose levels that we're testing, initially starting at dose level 1, and with a projected enrollment of 3 patients at each dose level, with up to 6 in the 3rd dose level, barring any toxicities being experienced. And to note, all the doses that are shown are based on purified CAR T cells that are greater than 94 to 95% purity or higher. So what has our experience been thus far? We have treated 3 large B-cell lymphoma patients to date, and at day 20 and greater, the percent cytokine release syndrome for all patients has been 0, as well as the maximum crest or neurotoxicity has been 0 for all 3 patients, meaning that during the first 28 days, no patient experienced any grade of cytokine release syndrome or neurotoxicity, which compares very favorably to what has been previously reported with the other clinical trials we've been speaking about, discussing during this talk, where at least the cytokine release syndrome has been anywhere from 50 to 90%, and at least a third of patients are having some degree of neurotoxicity, this has been very encouraging for our experience thus far. To the initial overall responses, 2 of the 3 patients had what we would call a favorable overall response, or 1 complete remission, 1 partial remission, and then a 3rd patient who, by the grading criteria, had stable disease, but as I will show in some of our follow-up slides, definitely had some degree of noticeable response in their tumor. This is our first patient. This is a patient who had previously been treated for a transformed large B-cell lymphoma, had actually undergone a previous autologous stem cell transplant, had relapse of disease, and was on a chemoimmunotherapy regimen prior to having progression of disease and coming onto our CAR T cell therapy. As you can see in the first silhouette, they had quite a bit of disease at the start of the CAR T cell, prior to CAR T cell infusion, with a large number of lymph nodes in the abdomen as well as in the left ankle region. The next diagram shows their response 30 days after CAR T cell infusion, and then at 85 days at CAR T cell infusion. The dark areas that are seen in the initial scan are indicative of active lymphoma, except excluding the brain and the bladder. And then this thyroid nodule is a little bit of a red herring. This is a hyperactive nodule that this patient has that has been previously biopsied multiple times and has not lymphomas. But as you can see, even at 30 days post-CAR and then at 85 days post-CAR, the patient has had a remarkable reduction of the lymphoma to the point where they're not seeing any evidence of the lymphoma itself, showing that they're in an ongoing complete remission. And this is a colored image showing their initial sites of their cancer, including in the abdominal region. As you can see, it completely fades away after the initial at day 30 and day 85, and then lesion at day 30 and has continued to be non-active at day 85. Let's go to our second patient. Now, this was a patient with a double-hit lymphoma initially had been treated with chemotherapy and undergone autologous stem cell transplant, and unfortunately had relapse of disease. And thus, at the time of the initial pre-CAR infusion, had quite a bit of disease, mostly centered in the left inguinal and groin area itself. And as you can see, at day 30 post the CAR T cells, it had a remarkable reduction in their overall disease status to just some small areas of activity in like the lower part of the left chest as well as that inguinal region. And when you look at the cross-sectional images of this disease burden, as you can see, there's this one little area that's lighting up this has been more or less unchanged, and then this large area of disease here that, as you can appreciate on the follow-up imaging, has shown a remarkably decrease in FDG or activity, brightness activity, and shows that a lot of the tumor is now very dark, which suggests it's just necrotic tissue. And then next we have our third patient. This is a patient that was treated for a large cell lymphoma approximately 5 years ago. Unfortunately had a relapse of disease and was put on salvage chemotherapy and then had progression of disease on the salvage chemo. As you can see, the patient has quite a bit of disease both in the chest and the abdomen. And following the chemotherapy, the CAR T cell infusion had a remarkable decrease in their overall disease burden. When you look at the cross-sectional images of the patient's scans, the patient initially had quite a very large lymph nodes behind the heart, completely had become unreactive post-CAR T cell therapy. They also had quite a large aggregate of lymph nodes lighting up in the abdomen, which had become completely inert on the follow-ups. And then they had some areas by the spleen and by the pancreas that were lighting up that are much decreased in activity on the follow-up scan. And then this one small area in the pelvis that had some activity previously and had but similar activity. One thing to note is that the PET scan that was done initially was done using a different technique than the first one. And on reviewing with nuclear medicine, they felt as this was a more or less a stable scan, but some difference in the imaging modalities. So, in general, this has been a very exciting time for us here at Loyola. We've had some very promising results with our first 3 patients. With the lack of toxicity, we have been able to get the okay from our review board to go with the phase, our dose level 2. So we're escalating the dose and continuing to see how well this goes, and hoping for ongoing toxicity and greater clinical efficacy. And all of this work has been in no small part due to all the support we have received for our cell therapy program from here at the Department of Medicine here at Loyola, Dr. Nishimura and his lab, as well as the Leukemia Research Foundation, and for all the patients, family, and healthcare workers who have made all of this possible. Thank you.